Well, welcome everyone to a wonderful March evening. This is Lessons from the Lab, and I'm Devon Rubin. I'm a neurologist at Mayo Clinic in Florida, and I'll be hosting this special edition of Lessons from the Lab. It's a Lessons from the Lab live. I've been looking forward to this. This is something that is a bit unique to what we've been doing, and if those of you aren't familiar with Lessons from the Lab, this is an educational series that AANEM has been doing for about maybe a year and a half now, and it's been really wonderful for me. I have usually I have a guest neurologist or physiatrist, an expert in neuromuscular disease or an EMG, and I present to them an unknown case. They don't know anything about it, and for that 45 minutes to an hour, we just discussed the approach to that case and intricacies to the case, and it's really been valuable for me and hopefully valuable for the readers or the listeners, the viewers, whatever you're listening on it too. And it's been eye-opening just to see the different approaches that we all take to come to the same conclusion. And I've gotten some good feedback. I hope there's a few people watching these. But some of the feedback that I've received is that, well, I'm watching this on YouTube and I'm shouting at the screen because I want to answer the questions. I want to tell you what I'm thinking. So that prompted us to think about doing a live version. And that's what we're going to be doing with you this evening. And so I'm lucky and fortunate to have a wonderful guest, an expert in EMG and neuromuscular disease, Dr. Ruple Laughlin. Dr. Laughlin is a professor of neurology at Mayo Clinic in Rochester and director of the EMG laboratory there. Hi, Ruple.
Guess
Oh,
what? I muted myself.
you're
Hi.
muted. Yeah. How you
I'm
doing?
practicing my mute and unmute. Thank
Yeah.
you for letting me be part of this very first Lessons from the Lab live. I'm really excited to be here and excited to hear all the input from our numerous attendees.
Yeah, this is going to be fun. I was thinking about this. You know what time of year it is, right? I know you know what time of year it is over the last 4 days. It's March and it's March Madness, right? I think.
Yeah, that's the only thing I know in my house. There's
Yeah, same
six
same with
brackets spread around my kitchen table, so I'm aware.
yeah, just constant like things going on TV and so I was thinking, well, this is going to be a lessons from the lab madness. So in a good way, we're going to get hopefully lots of input from a whole bunch of people all over the world, and we'll have our own little bracket and come to a final diagnosis. So,
Yeah. Well,
but
hopefully.
I appreciate you taking the time this evening to do this, and I thought we would just kind of jump right into it. And I have an interesting case for you that we saw in the EMG laboratory about a month or two ago.
Great. Do we
So
want to share? I know that people just joined. So, for those of you who think you may want to speak or do want to speak, um, just raise your hand and we will give you permission to speak. And then once you have that permission, you retain that permission. So, just then mute yourself after so you don't hear any background noise.
yeah, Rupo and we're pretty good at EMG. We're not very good at tech. So we were trying to figure this out for those of you joining. Um, so as Rupal said, we want this to be interactive if you're comfortable, but we don't want everyone speaking at once. So if as we go through the case, if we ask questions or you want to add anything, raise your hand. We'll allow you to talk, but then you have to unmute yourself. We aren't really going to be monitoring the chat or the Q&A. You can put things in there if you want, but it's a little hard for us to monitor everything. So feel free, but if we ignore you, don't take it personally. Okay. So this is the case. The case is a patient that we had in our EMG lab, and she was a 63-year-old woman who was referred through our spine clinic with left lower extremity pain and numbness. And she was healthy. She had hypertension, and that was it. No diabetes, no other medical problems. And about a year and a half ago, after a COVID vaccine, she noted some tightness in her left calf. It was kind of an achy tightness, pretty bad. And then soon after, and as you know, patients, the time frame is a little bit vague in terms of exact timing, but the pain began soon after the vaccine, maybe within the first couple weeks. She wasn't sure. And then over the next couple of weeks, she noted numbness in her left foot. And she described it as a decrease in sensation. It was in the bottom of her foot and more in the pinky and the fourth toe, the fourth and fifth toe. And and that was it. She didn't have any weakness that she was aware of. She had no bowel or bladder symptoms. She had no symptoms in her other leg, although she did note that 3 years ago, she had a period of time over the course of a few months where her right anterolateral thigh was numb, but that improved. So that wasn't a big issue. It was her left foot that was bothering her. And that was it. And on her exam, when we saw her in the lab, her exam really focused on her lower extremities. She had normal strength. She had an absent Achilles reflex on the left, on that symptomatic side, and she had decreased pinprick sensation on the plantar surface of her left foot. And the rest of her exam was fine. So that's the story. And before jumping into questions or anything, I'm curious, not in terms of your thought on this, but in terms of when you're working, you do a lot of education, you work with residents and fellows, and if when you're presenting a case to a fellow or they're present or resident and they're presenting to you, how do you approach that? How do you like them to think about it? They don't just rush into a diagnosis. So how do you approach it with a resident or fellow?
Well, I will say sometimes I do rush into a diagnosis, but then we usually like to backtrack a little bit. As you know, and I think most people on the call probably know, it's really easy to close be closed in your thoughts. And so usually what we start with is just kind of a summary sentence. So what is this? So it's a chronic 1 year history that started maybe acutely, subacutely after that COVID vaccination affecting, and then localization. So where is it affecting? And then trying to go through the neuroaxis as to where this could be coming from and what types of peripheral nervous system diseases would be thought of. So usually, I mean, I think residents and fellows will start from the muscle back to the spine and spinal column, and some will start the other way. But that's usually how I like to have them think about it. So then when they approach the electrodiagnostic study, they're looking at it holistically in that way.
Well, yeah, I think we do the same thing because we teach similarly. But and I think the nice thing about this live episode is there are quite a few participants, and I imagine there may be some residents and fellows here. So we're going to open this up for a moment. Would anyone care to share, so to take Dr. Laughlin's advice and go through in this case history, what do you think the potential localizations are? And if no one has to feel obligated to speak, but if you want to, just raise your hand. Okay, Mike, and I think you can unmute yourself.
I can, yeah. Well, I can get us started maybe. So kind of thinking through the neuraxis, like you mentioned, first I kind of do it the opposite way. I start at the nerve root and go down to the muscle. But so I would be thinking about like an S1 radiculopathy, given the diminished reflex at the ankle and some of the, distribution there. Could it be like a sacral plexopathy or something after the COVID vaccine, maybe? Could it be like a tibial mononeuropathy? She does have that history of this 3 years ago of this right thigh numbness. Like, could this be inflammatory focal nerve disease? And then probably less likely neuromuscular junction or muscle, just with some of the sensory loss and reflexes. So I would say probably radiculopathy or maybe mononeuropathy would be my highest on my list.
Okay, good. Thanks for sharing that. Anyone else on the call want to add anything or refute any of those? Okay, you're Dr. Mailing. You're able to unmute.
I think what Mike suggested was really good. The only thing I might add is just because of the vicinity, maybe a sural mononeuropathy as well should be something to take in consideration.
So do you think, and that's a great thought also. And Rupa, do you want to add anything to that or ask anything?
Well, the reflex being gone is one thing to kind of consider in that case. But I think it's something that you always have to kind of go through the patient's clinical symptomology to see what matches best. So that might be something that might lean you a little bit of a different way and implying some part of the motor arc there. But again, when we're checking reflexes, we're really invoking those 1A afferents, which is mostly sensory. So sure, thinking about a sural mononeuropathy. But I think what's important here is recognizing that there's sensory involvement and no motor involvement, which both of you guys highlighted in your differential.
Yeah. And I think someone in the chat, I am seeing a little pop-up also mentioned a fascicular sciatic neuropathy too. So thinking about all the potential localizations to throw that in is a good thought also. Yeah. Okay. What about the symptoms on the bottom of the foot? Does that help anyone or does that change anything? Maybe not. Okay. So somewhat okay. Tarsal tunnel. Someone's saying tarsal tunnel. Okay. Now remember, some of you may have come in late, so so this patient, after a year ago, after a COVID vaccine, developed pain in the calf, pretty bad pain in the calf, followed by numbness in the bottom of the left foot, same side. Yeah. So that's the history.
Looks like James has his hand up again. James, did you want to add something to that?
Yeah, just to add to, we had mentioned, or Mike had mentioned the tibial neuropathy before. So the bottom of the foot could be lateral plantar that's involved coming from the tibial nerve. And so it doesn't change it much for me because it could just be an extension of the tibial nerve we're seeing.
Mm-hmm. Okay. Great. So so Rupal, after I mean, we have these great residents and fellows given a nice differential. It's great when this happens and they're thinking through the localization. So then what's your next approach when you're discussing a case?
Then it's okay. So if we took Mike and James, who started, and I think Mike said S1 radiculopathy is kind of highest, then followed by a mononeuropathy, less likely something plexus. Then it's what studies do you want to do? So that's usually the next question is what studies do you want to do to help answer or push that question and why? So first starting with nerve conductions.
Well, wait. Do we have to start with nerve conductions?
We don't have to start with nerve conductions, but that's usually how I start my conversation. So with the nerve conductions, what nerve conductions would you want to do, if any, and why? And then typically we're doing needle examination after nerve conductions if we perform nerve conductions. So then it's based on those, what needle examination would you want? So I think that's usually how I frame the question is to understand. I think a lot of people they learn it, but then at some point they become very protocolized and maybe stop thinking about why they're doing what they're doing. So I like to make sure that there's an understanding, even though if there's some kind of protocol or consistent approach, the rationale behind it. So that's what I would ask next. So I'm happy to ask any of our panel or attendees what nerve conduction studies or needle or both. Would you not do nerve conductions in this case?
Well, no. So we've done these so many times. So when you ask me a question, I usually answer with a question back to you. So the question back to you is is there ever a scenario where you do a needle exam before you do nerve conductions?
Sure. I'm trying to think of when that would be. I think if it were in this case, probably not, because the majority of the patient's clinical symptoms are sensory. And so my needle examination may actually be less telling than my nerve conduction studies. But I think in a motor predominant process where I'm really highly thinking that there's only motor involvement, maybe I would do that to help guide me as to what additional nerve conductions I would need to do. I think more often what happens for me is that we start with nerve conductions and needle examination typically doesn't surprise you if you've done your focus exam, but sometimes it will, and that will cause additional nerve conduction studies.
Yeah, and I'm not advocating to do needle first. I'm just saying we, like you said, we are protocolized, right? And we're fortunate where we both work that we have busy labs but great techs, and they know what to do, so they go in and do the conductions first, and it's sort of that's how we do it. People who are in a situation where they don't have techs and they're doing everything, sometimes doing a needle exam first might be useful. The times I do the needle first mostly are when we're backed up in our lab and the techs are, still doing studies, and we have a bunch of patients waiting, and they say, can you needle this patient first? And it's kind of, a non-specific back pain. But sometimes even like a myopathy, someone with, and this isn't the case, but someone who comes in with weakness, high CK, you think it's myopathy, I might do the needle first. And then if it's clearly a myopathy, just do a couple conduction studies instead of embarking on a whole bunch of studies.
Yep. And I think those are the cases where I would agree. The other group would be like in repeat studies like brachial plexopathies, where all the responses were gone, and really the question is, has there been any reinnervation? I might start with the needle and then talk to the patient and go to the sensory.
Okay.
So does anybody else have a different strategy?
Well, I saw a list of conduction studies that were suggested that popped up. So I'm gonna take this one at a time though. So what would people start with? What would be their first thing that they do in the lab after the history and all the stuff we've talked about? Anyone want to start? What's your first study? What's your first electrodiagnostic study? Assuming we do nerve conductions first.
Someone in the Q&A wrote Searle.
Searle, okay. Okay. Tibial, AH, okay. Anyone for anything else? There's no right or wrong answer here, right? Well, the healthy side, okay, good thought. Good thought. You might do the healthy side. And there's let's see. Okay, you, Dr. Bocelli, do you want to speak?
Sure. I was just going to clarify. I would do both, probably the Searle first, and I would do the healthy side, and then as well as the affected side. The same thing for the H reflex. That would probably be what I would start with for this patient.
Okay. Great. All right. Well, these are great ideas. And what I'm going to do, I'm going to just share my screen. Hopefully this will work. And I'm going to show you what we started with. So can you see that?
Yes, I see the fibular motor study.
And hopefully this isn't being blocked here. Okay, so we started in our lab. This is, again, for those of you who joined, left leg, calf pain, and numbness in the bottom of the left foot in a 63-year-old woman. That's the story. And so this was the left fibular motor study. So when I show my screen, I lose the ability to see everyone's comments and raising their hand. So any thoughts on this? Or Ruple, you want to?
And yeah, I can pull up the participant screen too in case somebody wants to comment. My first question to you, well, so for those of you who are not familiar with these screens and these colors, in our labs, our normal values are highlighted, and if they're green, they're within normal range, and if they're pink or red, they're outside normal range. So just quickly looking at the results, they look normal, but more importantly, looking at the waveforms, they look like normal studies. But my question for you, Devon, is why did you do the fibular head? Do you always do the fibular head?
That's a question I always ask our techs too, why they do it. And that's a valid question. I don't know why they did it in this situation. So, why would or wouldn't you do it? I can always ask you a question back.
Well, I don't see a reason to do it in this case. Typically, I mean, if I had a very high index of suspicion for a compressive fibular neuropathy, maybe I would do it even in a situation where it didn't meet our quote unquote criteria. But typically, unless there's a 20% drop in amplitude across that long segment, we're not routinely doing it. Again, if there's a high index of suspicion, then maybe, but here it's a 10% at most change.
Yeah.
Um,
and there's no slowing either.
and there's no
so
slowing.
I agree.
So that's the other reason, if there was any evidence of focal slowing in that same, or slowing, absolute slowing. So I don't think I would have done it, especially in this patient where the distribution of findings are not really in the fibular distribution.
Yeah. So apart from doing too many shocks here, given stimulating another site that probably didn't need to, any thoughts about this study from you or anyone? Any other concerns, I should say?
I think it looks good. Otherwise,
looks pretty good. Yeah, and like Ruple said, green means, just so we don't have to go through all of our normal values, but green means the distal latency, the amplitude, which we take from the knee, and the conduction velocity are all within our normal values. So would you do F waves here?
Well, if my highest concern is really that of a radiculopathy, F waves are not really helpful, because usually there's multiple different nerve roots that are being attributed to this fibular motor, so they're not very specific in that sense. In addition, the fibular motor response, or the fibular motor F wave, can be absent in normal people, so I don't know what I would make of it here. I think if I were really worried about a neuropathic condition, then maybe I would do them.
Okay. And I'm just gonna just from a technical tech standpoint, not nerve conduction tech, from a AV tech, if anyone who has already spoken wants to add anything, feel free to unmute. And if you want to add anything and you haven't spoken, raise your hand and Anna will unmute you, allow you to unmute.
And I can see them too. And there was a comment in the chat that one of our attendees says they always do the fibular head because it's such a common site of compression. And again, I don't think that's a wrong answer or right answer. I just don't think it's our convention. Mostly to save the patient additional shocks when there's a low index of suspicion for a focal finding.
Yeah, and I think that's a good point to reiterate. I mean, here I agree with you. I don't know why our techs did it. And you could argue carpal tunnel is a common site of compression. So why didn't we just go up and do the hand here? Just so obviously I'm being a bit facetious because they didn't have hand symptoms, but I agree with you that the symptoms were on the bottom of the foot. And if you look at the absence of a block of a drop of more than 20%, absence of slowing of velocity, we're not really concerned about there being a subtle subclinical fibular neuropathy here. So, all right. So we did do F waves here, and I'm going to just kind of help. I'm not going to ask you on every waveform, but well, let me ask you. Yeah. So fibular F waves are tough, right? We often don't get them. So you think these look okay?
Yeah, they look okay. I mean,
you don't sound so convinced.
Oh, well, I mean, like, I'm looking at the first two, and then I'm looking at that third one, and that's I mean, maybe if we looked harder, I mean, if you want to mark the onset of the earliest two, we did that, and it's probably at the right mark.
Here and here. Can you see my cursor?
Yes.
Yeah, my mouse.
You can see your cursor.
Yeah.
But I mean, I think like the third and the seventh and eighth, I mean, that's a lot of chronodispersion in terms of where that one's hitting, and it doesn't look like there's components. Can you see my cursor? Probably not.
No.
That are earlier. So
yeah. So
I think they're marked correctly, but they're kind of goofy.
They're kind of goofy, but many times you don't get them at all.
Right.
So do you think these are real F waves?
I think they're real F waves.
Yeah, I do too. I mean, they look different a little bit. These two look the same, and these two similar, but yeah. So I would say this doesn't help us a whole lot in terms of our localization, right?
Right.
Okay, so then what we did is we did the left tibial.
This is the bad side.
This is the bad side, yeah, the affected side. 63-year-old.
So these values are, well, does anybody else want to say what they think of these values? I mean, I guess it has to be somebody who knows our values, but these
well, they're
are
green. Yeah.
right. Well, they're green. They're normal. And yes, there's a 24% drop here, but in the tibial nerve, we allow a 50% drop in the long segment. So this is not focal per se. It did take quite a bit of stimulus intensity to get that knee response, which is not uncommon. But I think that the fact that we're not at 100 and we didn't have to increase our duration, I believe that we're probably super maximal. But those are things I think that are important to look at on the tibial nerve before you over interpret.
Yeah, and I don't remember this patient's body habitus, but and it may be hard to see, but 89 milliamps at the ankle, we're very picky, we're compulsive. That seems to be a lot at the ankle. So maybe this tech just was in the mood for shocking, an extra site and giving a lot. But we're not going to get into all the technical things to do, but making sure you're sliding, you're over the nerve, things like that are important. So, okay. Does this waveform bother anyone on the call? Everyone comfortable with this? Okay. So our next nerve, so we've done the fibular and we did tibial F waves here as well. So what do you think? What about this?
These are really ugly.
I think they're beautiful, but why do you think they're ugly?
I think they're ugly because they're ugly. There's just there's a lot of that doesn't look like movement artifact. That just looks like there's a lot of I mean, sometimes you can get that where you get a lot of movement and so you can't get a really nice waveform. I'm talking about especially to the right or later.
Yes.
Yes. And I think again, these are probably marked correctly. Those earlier responses just to the left of your marker, they almost look like they're superimposable. So are those A waves or just early other waves? But
so you don't think these are F waves?
Oh no, I think they're kind of F induced repetitive discharges in a way, but they're not superimposable. But I think those are F waves. I don't think that they're all movement.
Yeah, I agree. I mean, I think these are F waves. This is at 100 microvolts per division too.
Yeah.
So I think they're tall F waves. And I agree with you. These I'm suspicious about these being more A waves. Mm-hmm. But the issue would be then if these are A waves, long. Then this is already long compared to our F estimate. We estimate how long the F wave should be compared based on the known conduction velocity in the tibial nerve. And if it's marked here, this is longer than it should be. And if these aren't F waves, if they're out here, it's even longer.
Yeah, that would be very long. That's probably why it was marked there, just to kind of get it closer to normal. But I'm not quite sure that is where I would mark it.
So if this truly is a prolonged F wave compared to the F estimate, what does that mean? Like,
well, can we ask somebody in the audience
sure.
what that means? And then I will tell you what that means, what I think it means.
Yeah. Any attendees want to comment?
I know not everybody uses F estimates, so it might be difficult to answer that. But for those of you who do, does anyone want to interpret what happened, even in this case, where the F estimate is longer than, or the F wave is longer than estimate? Any takers? I see familiar names, but I'm not going to make you talk. Reese.
Well, I might have to.
So wouldn't it indicate that there's proximal slowing?
Are you asking me or are you telling me?
I'm telling you.
Yes. Yes, it should indicate proximal slowing. So what our F estimate allows us to do, thank you, Reese, is it will take into account the conduction velocity in that segment that we just measured the conduction in previously.
Right here.
So it presumes that the whole nerve is conducting at 57 meters per second. And what it does is it allows us to measure, we use a distance, and here it's the xiphoid as to where that anterior horn would be sitting. And it lets us estimate how long it should take if the nerve is conducting at 57 meters per second for that F wave response to go all the way up and come all the way back down. And so it should take 41.7 seconds at that distance of 1,070 millimeters, which is kind of up and all the way back down. But it took 49.8. So it took 8 milliseconds longer, and maybe much longer, depending on where you really mark that, than estimate. So we know how fast the nerve was going in the measured segment. So the only place it could have slowed down was the proximal segment of the nerve. And that's how the estimate can help you in conditions, especially when there's another pathology like a peripheral neuropathy or something else that's already slowing down the nerve, and you're looking for superimposed proximal slowing. So in this case, Devon, to answer your question, is it would imply proximal slowing of the motor segment of the nerve.
And so when we think about the differential that was listed at the beginning in terms of localization, then it would take out, I mean, it would be, when you say proximal, just to clarify for everyone, you're talking about proximal to the knee.
Right. It would have to be proximal to the knee.
So sciatic nerve, plexus, root. Okay. Cord? Can you get a prolonged F wave in a cord lesion?
With the cord, if you had, well,
I don't know. Probably not this long. I would say if you had some demyelination in the cord, or right at the very root level, but I don't think you get long F waves there, right? Because you have such a small segment, you have to have demyelination there,
right,
and you're
again,
really at the anterior horn cell.
Multiple different roots, so.
Yeah. Okay. All right. So so really all we have.
Well, I wonder.
Oh, go ahead.
Would cord disease cause abnormally absent F waves, like a tibial or a ulnar F wave where you would expect it to be there?
Like, so it just gone all the way.
Yeah.
That's what I would predict.
You could, yeah. Yeah, it probably wouldn't cause prolongation. It would just be loss of F waves. Yeah. But that would have to be cord affecting anterior horn cells. So just for clarification, if you had a posterior column problem, obviously it's not going to. Yeah. Yeah. Okay. So moving on here. So we have a normal fibular, we have a normal tibial motor, we have a prolonged tibial F wave. And then what we did here is we did the sural. So A, B, and C point, 7 centimeters, 14, and 21 centimeters. And she's 63. So what do you think here?
Well, in our lab, we allow them to be absent after 60. That's why nothing's highlighted, because 0 is normal. So you have to kind of take that into consideration. But I guess the important thing is it's present. So here is a case where, especially now that we're thinking something more proximal, we're looking at the other side, with a side-to-side comparison might become important, because it's present. And although it's normal, is it robustly normal on the contralateral side? And I don't know if I love your C point, but that's an aside.
I'm gonna tell our tech who did this. I'm gonna have you call them next week.
Well, they average 5, so I'm assuming
they average 5. Yeah.
Yeah.
So let me ask you this. So you're saying 5 is technically, so our amplitudes are from B point, this one. So in a 63-year-old, 5 is technically within normal limits. If this was a 93-year-old, would this be within normal limits? Like, would you be comfortable this is normal?
Well, and anybody over 60, theoretically, if they have anything, we're calling it normal. But I think usually then we're starting to look at 8 point, instead, that 8 point should always be there and above a certain microvolt level. In a 90-year-old, if you had a sural, I'd be happy.
Yeah. Okay.
I have a hand up.
Yeah, I just muted. Dr. Alnabi, you can unmute and speak. Do you want to?
Yes.
Did I unmute you?
Hello.
Yeah. Hi.
Hi, how are you?
Good.
I guess we should check the other side and do not stick to the age. If the other side is good and the amplitude is fine, we can say that we can use the comparison in interpreting our case. If it's absent, we cannot depend on one side is absent and the other is low. This means that only if we get a good response, this will be useful.
Okay, good point. Yeah. So, and I guess I would just add maybe Rupal, I'll ask you. I think you would agree, but what would be a good response? When she says good response, what would make you think this is abnormal?
So on the contralateral side, you mean?
Yeah.
Yeah, so usually we're looking for a 50% side to side difference. So if the other side were 10 or higher, that would make me pretty comfortable to say this is abnormal on this side.
Yeah. Okay. So I'm going to go on. And so just show we also did the medial plantar. So 63-year-old, amplitudes 2. And I know you're going to say you're not happy with this one. Right. But so maybe I'm going to just put words in your mouth. Maybe it's there, maybe not. Right.
Yeah. And I mean, again, it's really hard when you're not in the case and you don't see all the time lock stimuli. So this could very certainly be present. It's just when you get one shot of the average response and the baseline that is typical of a sensory response, you always have to look at it with a grain of salt. And I think what I'm trying to say there is you have to look at your waveforms. You can't just rely on your numbers. Because the computer can mark whatever it wants to mark. So just emphasizing that you should always be looking at your waveforms.
And I always tell our techs, and if you have techs that do your conductions and they put the markings on, these marks are trickery. They're complete trickery to your eyes. Because when you put the marks on, I could put a mark right here and right here, and it's going to look like there's a response. So you have to be really careful. And and same with like somatosensor evoked potentials. Move the marks, just look at the waveforms and see, do you really think that there's something reliable there? And I would agree that, without the marks, I'm not sure. What is this? What do you think this is?
Oh, I think that's probably the slow motor response following.
Yeah. So this all could be just the baseline, and then you're getting the motor artifact from stimulating the bottom of the foot. Yeah. But that's what we got. And maybe they said, oh, she's 63, you don't get good plantars, so they didn't spend a whole lot of time. So they did go to the other side. So in this case, they did the affected side first, and then they went on to the other side. And the fibular 5.7, I think it was 4.8, I believe. So on the other side here, they didn't do below the head. So it's pretty similar.
Yeah, I mean, so again, it's bigger, but probably not outside the realm of just the side to side comparison, especially over the EDB.
Yeah. And then they didn't do F waves there, but they did the tibial motor.
Now the tibial motor is considerably bigger, I think. I kind of remember the other one being in the 5 range.
Yeah. So that's interesting, right? Because the other one looked pretty good.
Yeah.
So you would
normal.
think, yeah, but you think this now? Would that make you think the other one's not normal?
Absolutely. Does anybody else have a thought on that? How would you all interpret this? Can you just click back quick to the other one?
Yeah. So there.
5.6.
5.6 and 7.4 distal, and then 14 and 12.5.
Yeah, absolutely. I mean, I think that this is a big, significant difference of, over 50%. So it makes me think that the one on the left is low amplitude response, comparative.
And that's helpful too, because although the patient is just coming in with pure sensory complaints, this is a motor response telling you that there's at least subclinical motor involvement.
Yeah. I think there's a comment, Dr. Alnabi. You just have to unmute yourself. I think. Go ahead.
Also, there is a temporal dispersion on the affected site.
Well, on the tibial,
Yeah.
yeah.
Somewhat.
So why do you think there's temporal dispersion here? It depends on the duration increase. There is a little bit of a duration increase there.
Yeah.
And there's
Yeah.
different criteria for duration increase to say there's temporal dispersion. Some people will say 15%, some people will say up to 30% increase. And that's what, I guess that's 20% or so, 20.
Yeah.
Yeah. So maybe a little bit, maybe. I'm
Yeah.
not sure. Rupa, what do you think? Would you call that dispersion?
I wouldn't, I'm pretty conservative about calling that though. So I usually use that 30%, not the 15, to call it. And then especially at the tibial, again, we were really high in our stimulus intensity. It's hard to get under the knee. I mean, so there's other technical parameters that I think might be, you could overstate it. And I think if you know what you mean, you're fine. But when you start using words like temporal dispersion in reports for people who don't know what that means, they start thinking about acquired demyelination and they start thinking about treatment. And you just want to make sure you're not overstating what you think.
But it's also important from a localization, because if you think this is true temporal dispersion, I agree with you. I would not call this temporal dispersion. Then the at least in part, the lesion has to be between the ankle and the knee versus proximal to the knee. It's a completely different localization, or there's two sites of involvement.
Or right?
Yeah, it could be two. Right. So, okay. So, and then we did the Searle on the right side.
So now I believe that one.
You believe this, Searle? And you believe the other one's abnormal?
I believe the other one's abnormal, and I believe that one very well. So the other one was 5?
Yeah, the other one was 5 at B point. This side, we only did B point.
Yeah, and that B point is even bigger than your A point.
It's 26. So 5 versus 26. So even though my math skills aren't good, I know that's more than 50%. So you want to guess what the medial plantar is?
8.
And I ask jokingly, but not so jokingly, and I was discussing this with someone recently, that when I go into a conduction study or a needle exam, I do this with our techs. If they go back in to do something, I tell them, this is what you're going to get. This is the number, the amplitude you're going to get. Because I think with experience, you kind of have a sense, and of course I'm wrong all the time, but I have an idea what I'm going to get, what I think I'm going to get, because I have an idea what I think the localization may be. So I like to play that game and say, okay, based now on this being asymmetric, maybe it's going to be asymmetric on the plantar too. So what did you say?
I said 8.
You said 8. 12. You're close.
Yeah. Well, it's at least 4 times more, maybe 6 times more.
Yeah. So, and clearly a response here, right?
Yes.
So I'm going to pause for a second and maybe open it up to someone on the call. Based on the conduction studies, what are you thinking now in terms of localization? Anyone want to narrow the possibilities?
We do have one person in the chat that thought it was a plexopathy. I don't know if you want to come off mute and share why, or if anybody else wants to add localization or confirm. Or James or Mike, you guys started this off. Do you guys have any thoughts? So
yeah,
go ahead, James.
So one thing I think of is that, yeah, sure, plexus could be involved. Although our nerve conduction studies, all we've looked at really right now is the sciatic nerve and the branches that come from it. So it could be as well the tibial portion of the sciatic, and then you can have a portion of that tibial that then contributes to the sural. So I think that we need to keep looking with needle would be my thought.
Could this be a tibial neuropathy? Could this be tarsal tunnel? Or anyone? What do you think, Rupe? Oh,
Well,
yeah.
Dr. Sutter said tibial neuropathy. Dr. Sutter, do you want to expound on that at all? Okay, so she's got to take a break here. So I think that those F waves kind of apply. So you specifically asked about tarsal tunnel. So the sural being so asymmetrical would kind of guide me away from a distal tibial neuropathy at least. A more proximal tibial neuropathy, I guess, is plausible, but you know the sural gets branches from not just the tibial but also fibular. So it seems like we're outside of just the tibial. But I agree wholeheartedly with Dr. Meiling that we really need our needle to help us here with localization.
Yeah.
And I think what's helpful in addition is knowing that because there are motor abnormalities on nerve conduction studies that our needle will be helpful. So back to your original question, you know, in this patient who was just coming in with just sensory symptoms, I was concerned that we wouldn't have any, would we find anything on needle because it was just sensory. But now I would expect to see something with those CMAPs being as asymmetrically low as they are.
Yeah. And then the other question, common things being common, the first thing that we all think about is this an S1 radiculopathy? And can we exclude that, do you think?
Well, I think that, you know, we learned that in preganglionic or root disease, your sensory should be normal. But if you have a far enough, lateral enough disc, you can kind of pinch, you can get involvement, especially at L5 and even S1 of the dorsal root ganglion and almost mimic a postganglionic appearance. So I don't think it can be absolutely excluded, but it seems less likely.
Yeah. And I think that what we teach, we know that in L5 radiculopathies, the superficial fibular can clearly be abnormal. There are nice studies. The sural, I think I agree with you. It can be in an S1, but it's
very uncommon.
Very uncommon. Yeah. So I think I would agree that that would make me not think that this is a root problem and more either plexopathy or sciatic neuropathy. So I'm going to ask you this next question because you know, we could spend 3 hours breaking down this case and we're coming up on the hour. So we've got a little time and I have a couple other things I just want to touch on, but I'm going to just ask you as if you're a resident. Okay, let's go back many years now.
many years.
Tell me what muscle you want to stick first and I'll tell you what it shows.
Okay, so I think, you know, it's always the game. If you could only stick one muscle, what would it be? So I think this is not the way I would approach the test, but if you were just wanting me to do one, I might pick the long head biceps femoris or semimembranosus or semitendinosus just to get a sciatic S1 muscle.
All right, but what would you do in real life?
In real life, I would start with the probably anterior tibialis.
Okay, so it shows 1+ fibs and 1+ long duration motor unit potentials.
That's surprising. Okay, that's helpful. And then what about the medial gastroc?
This is like the boards, you know, all of you who don't have the oral boards
John
anymore,
Kincaid tested me for the oral boards, so I remember that really vividly.
Yeah, this is how it used to be. So I'm bringing back memories. So fit 1+ fibs and 1+ long in the AT.
Okay, medial gastroc.
Same thing, 1+ fibs and 1+ long duration.
Okay, and then we'll just kind of finish our quote root screen, our vastus.
Normal.
Okay. TFL.
Normal.
Gmax.
Normal.
Okay, so we're kind of in.
So what? Yeah, what are you thinking now? Just with that.
Well, I mean, so with the fibular and tibial involved, I'm thinking it's going to be sciatic. So we have a fibular muscle as tibial muscle. We don't have any proximal L5 or S1 muscles involved that are not outside of the sciatic distribution. So now I would probably want to look at a sciatic innervated muscle. And because both the fibular and tibial nerves are affected by needle, even though we didn't see that asymmetry on the fibular motor conductions, I'd probably pick a tibial leaning sciatic, but I don't think it matters because we have the fibular involved.
Okay. And there was a hand up, a comment?
Somebody said posterior tib and somebody said hamstring.
Okay. Yeah, I mean, the posterior tib, I guess I would argue, how much does that add right? Right? Because you already have the medial gastroc that's abnormal, and you have the anterior tib, and you know it's probably not root because the proximal L5 S1s are normal. So both the biceps femoris were performed, long head and short head, and both showed 1+ fibs and 1+ long duration motor units.
All right. And then did you do sacroparaspinals? I don't know that you necessarily have.
The sacroparaspinals weren't done in this patient. No. So would you have done it?
Well, I think that you have enough, and again, back to the postganglionic localization based on the sensory nerve conduction studies, I don't know how much it would add. Sometimes I do think that when it's, you know, an acute condition, like if this came on 3 or 4 weeks ago and we were trying to decide on S1 versus something else, it would be maybe relevant because that might be the first muscle that we would see any changes in. A year later, with the nerve conduction localization, clear needle localization to the sciatic nerve, and no involvement outside of the sciatic distribution in proximal L5 or S1 muscles, I don't know that it would add much.
Yeah, and you know how real life is, because then you stick the sacroparaspinals and there's a few fibrillations, and then
Yeah,
you're like, what do I do with this now? Is it root and it's affecting the sensories? And then it, I'd say it comes back down to the history. I didn't give you no one, we did the history real quickly, but there was no back pain at all. It was all calf and foot. So to me, just based on the history, that would be unusual for a root problem. Doesn't exclude it, but that would make me think less likely. So I don't think it would be wrong to needle the paraspinals here, but it might muddy things up a little bit too.
Right. And so that goes back to your original first question to me, which is, why are you doing it? So if you get into this is what I always do in every leg, sometimes you're going to wind up with answers that you don't know how to explain. So I don't know that it might, like you said, confuse you more than add much. If it's normal, I guess it's just one more normal, but you already have proximal muscles, I think, that answer that question for you.
Yeah. So in the last, I just have one or two more questions, and then I want to leave about 5 minutes for any questions from the attendees. So if you thought this was a sciatic neuropathy, which it certainly looks like, that's happened subacutely after COVID, a COVID vaccine, would you do anything in terms of workup? What are you thinking is the cause? And just kind of briefly, how would you approach this patient after you got the EMG?
Yeah, so I think we can see in neuritis. I mean, there have been cases of neuritis or radiculitis or after vaccination or inflammatory conditions. So I think in this patient, I would image the sciatic nerve if I could. Some people had suggested ultrasound as an imaging modality. I probably would go to MRI just because my affinity towards the sciatic nerve with the ultrasounds that we have attached to our machines, I would worry a little bit about what I could see, although I'm sure there's people on this chat that would say otherwise. But I think imaging would probably be the next step.
Yeah. And the imaging in this patient had here's the sciatic nerve, and had the radiologist thought there was a bit of enhancement of some of the fascicles of the sciatic nerve, maybe some enlargement of the fascicles as well. So, I guess the question is you think this is inflammatory? I mean, it was after COVID vaccine. There was no other cause. Can you get after vaccine? Can someone get an inflammatory nerve problem?
Well, I think you can get anything after anything because there are cytokines, but I do think that there have been reports of these, as you have, just a lot of different cases of people having focal neurologic, true neurologic issues with COVID, but not just with COVID, but also with the vaccine.
Yeah, and the history was vague. It did have a sort of a feel of a Parsonage-Turner type of syndrome, obviously not in the arm, but I just put a couple references here for anyone watching this, that there have been some reports of neuralgic amyotrophy, Parsonage-Turner after COVID, and there have been studies looking at the risk of that after COVID vaccinations, showing that there is a slightly slightly higher risk, but it's low, but it's similar to the risk of influenza vaccine and Parsonage-Turner here. The other point I want to say, and then I just want to open it up for any questions, is there's a nice paper on sciatic neuropathies because they're not common. We see lots of other mononeuropathies, but this was a series from Cleveland Clinic that was published in Muscle and Nerve on non-traumatic sciatic neuropathies. And most of them were, as we know, related to hip surgery and stretch injury of the sciatic nerve. But there was a small number in their series. They had about 109 patients that were inflammatory or vasculitic. So, this is a nice review paper for those of you who are interested that was published back in 2019. So our thought was that this was inflammatory. I'm going to just stop sharing here. That this was inflammatory. It's not my patient, but in following her chart, she was improving. She was not worsening. So I think they just kind of managed her conservatively, and she's been doing better. So, but I think there's a couple instructive points here, especially from an EMG standpoint. The thing that if you don't look at the patient and you just look at the electrophysiology, it looks pretty good if you only do the one side, right? Or if you thought the sural was low and the plantar was low, if let's say the patient was 55, you might say, well, this is just neuropathy. But it was only one side. It didn't fit with the story. So I think, as we always say, you have to put the electrophysiology into the context of the patient's clinical symptoms and the importance of side-to-side comparison. I don't know what,
I totally agree. And I think that the converse is also true. I know that Zach London and his group also did a study looking at the value of doing bilateral nerve conduction studies in patients with typical symmetrical neuropathy. And there's really no reason to do that. There was no increased yield. So you have to look when you have to look. But I think it's the savviness of thinking, okay, could this still be in the realm of abnormal? And there are times where, some of you have tech, some of you don't, but we will be, we'll ask the technician to go back and do a study with a very normal response. And you can feel them saying, why am I doing this? And then you feel kind of validated when they come out and it is, 100% or twice the amplitude of the other side, because you've seen the patient clinically, you've examined them, what may or may not be expected.
Yeah, there was a question about subdermal needles for sensories. We don't use those. Yeah, you could, but you have to be careful about that. Because the closer the needle is to the nerve, that's going to affect the amplitude. Just like on needle exam, if you move the needle closer to a motor unit, the amplitude changes. So if you're comparing side-to-side amplitude, yeah, you might get a response on a small sensory, but you have to be careful if you're comparing side to side with that. So
there was another question in the chat asking, would you have done the paraspinals if you had TFL involvement? So I'm going to ask you.
You want me to answer, or you want me to ask you back?
No, yeah, I'm going to ask you.
Absolutely. So, thinking localization, if the TFL or the gluteus maximus was involved, now it's not sciatic, right? It's plexus or root. And then I would absolutely do it. If there were similar findings in the paraspinals, that would make me suggest root. Now, you're still in a sticky situation if the sensories are affected. Now, either it's root and it's one of these rare cases that the sensory dorsal ganglion is knocked out from the root, or it's a combination, or there's some other reason for the changes in the paraspinals. They've had injections or surgery or something like that. So those get a little tough. That what I find more frustrating is someone who has a radiculopathy, a classic symptom. You find changes in the leg and you do the paraspinals, you don't find them there. And you stick several times, you do mapping, however you do it, and it's just hard to find the fibs, and yet there's 2+ fibs distally. Those are the ones that frustrate me. And I always think it's probably that I'm just not in the right spot, that you have to go really deep sometimes to see the fibrillations. I don't know if you ever have that.
Yeah. I definitely do. And I agree, it is frustrating.
Yeah. I know, Ruple, you have a hard stop, I think, at 8. So I'm going to stay on for some questions, but I appreciate that you've taken your time.
Oh, I appreciate being invited.
we talk about these cases all the time, and we could talk for 3 hours about any case, and it's a lot of fun, and we'll definitely do another one of these with together and with others.
Absolutely. And I thank everybody for attending and your input and your communication. And I hope this worked out okay. I know that we were like doing chat and questions and unmuting, but it's always very fun. And of course, electrodiagnostics is very fun. So thinking through a case is great. Thank you for the invitation.
Yeah. Well, go enjoy the rest of your evening. I'm gonna stay on. I don't think we're cut off, so I'll let you go. I'll stay on and answer a few questions for a few minutes.
Absolutely.
And
Thank you so much.
all right. Bye. See ya. All right. There are a lot of questions coming through. So let me see if I can find a couple of these. I think someone said, so you're asking me questions in Q&A and in chat. So I'm going to do my best to see some of these, but do I treat if it's inflammatory? For her, I would not, because it was so long ago and she's improved. But if I thought it was inflammatory, I think that's debatable. There really isn't. If you think about Parsonage Turner, there really isn't great evidence to suggest that steroids help reduce the severity or the outcome in Parsonage Turner syndrome. Most of the time, we don't catch them early enough, so it's hard to treat them until usually it's several weeks out before we see them. So you could, but I don't know that there's great evidence to support that. All right, let me try to get a couple others. If anyone want to just raise your hand, I think I see our hand raised. Let's see. Okay, Dr. Server.
Hey, can you hear me, Dr. Rubin?
Yeah, speak a little louder.
Hey, can you hear me?
Yes.
Hey, so just curious, in your lab, would your techs have normally done bilateral nerve conductions in this specific patient? Or is this one, like you were referring to in the beginning, that you would have done, unilateral nerve conduction, done the needle study, saw what it showed, and then went back to do side-to-side comparison?
Yeah,
Just given that the unilateral symptomatic side was technically normal
yeah,
initially.
it's a good question what our techs would have done. I think we have really good techs, but they're not physicians. And they're not as, even though they're experienced, they're not as experienced with the complex situations. So I always tell them, it really makes me feel good if you've thought that, hey, this sounds like it could be a sciatic nerve problem, and that you go over to the other side and do it. And some of our techs do that, and some might have just done the one side and said, she's 63, these are normal for her. And then I would have done the needle, talked to the patient, done the needle, and then had them go back in. So it really kind of depends on the tech. I like when they are thinking like I am, but this it wouldn't be unreasonable for them to say, it sounds like a radiculopathy. I got responses in the sensories. This is normal, and not do the other side. Good question. Yes, a beer.
Hello, Dr. Robin. Do you hear me
Hi.
well?
Yes, I can hear you.
Thank you so much for the excellent webinar. It's always nice to listen to you.
Thanks.
I was asking about how long could it take post-COVID so that we can relate it to the COVID or the vaccine. We've been seeing CIDP cases so frequently lately with no positive history except for a COVID vaccine or an infection that we don't call COVID anymore. It's like months before. Could it still be related, and to how long?
I don't, that's a really good question. I don't know the answer to that. I think the Parsonage Turner syndromes, so the horrible pain followed by neurologic deficits, those typically are within a week or a few days, a week, maybe 2 weeks after a vaccine. So if someone's had a vaccination, this is a more general, and then 3 months later they get horrible pain and weakness, I think it would be unusual to be an inflammatory response from the vaccine. I think the CIDPs after COVID and the neuropathies, I think, are much more difficult. I think there's a variety of causes or associations, or maybe not an association. So I think the ones that trickle along later on, I'm not sure. I don't know that it's easy. It's not easy to determine, is there a relationship between COVID and the neuropathy? So
Thank you so much.
you're welcome. Yes, Dr. Barami.
Hi, Dr. Rubin.
Hi.
Do you hear me?
Yes, I can hear you.
Is it useful to use somatosensory evacuate potential in these cases to differentiate as plexopathy or tibial sciatic problem?
I don't think so. We would not use that in our laboratory. And the reason is, I think there are two reasons. One is, if you're stimulating the tibial nerve and you're recording responses along the spine and the scalp, you could have prolongation of the latencies if it's a problem in the sciatic nerve or the plexus or the root, theoretically. So it doesn't help you in localization. The other problem is that if there's slowing in a small area of the sciatic nerve, you're looking with an SEP over a long distance. So everything else may be conducting normally. So the sensitivity of the SEP is going to be very low at identifying the cause. So I wouldn't use that to make the diagnosis. I would rely more on the standard conduction studies. Now, you could argue a similar thing with H reflexes. You may know we didn't talk about H reflexes because we didn't do them. We don't do H reflexes commonly in our lab. And the same thing, if the H reflex or H wave was prolonged, that could be a problem in the sciatic nerve. It could be a plexus or it could be a root. So it doesn't really help narrow the localization. It would support that there's a problem along the pathway, but it doesn't help in localization. So good question.
Thank you.
You're welcome. Dr.
Hello.
Yang. Yes.
Hi. Great talk, Dr. Rubin. Just a quick question about lumbar plexus parsonage Turner. Do you know if certain nerve fibers are more affected, like in the upper limb, like certain nerves tend to be more affected or certain muscles tend to be more affected? Is that the case for lumbar plexi?
Yeah, good question. So first of all, as you probably know, inflammatory lumbosacral plexus neuropathies are much less common, except for diabetics, than Parsons Turner involving the brachial plexus or upper arm. So the non-diabetics are much less common. And the other thing is that the lumbosacral plexus doesn't have as many nerves coming off of it as the brachial plexus, right? So the most common nerves that are affected in Parsons Turner, it's the long thoracic, suprascapular nerve, some of those nerves coming off of the plexus, and you just don't have as many options in the lumbosacral plexus. So I think that's a long answer to say usually it's the plexus itself, either the lumbar or the sacral, but you can have them, as in this case, you can have individual nerves. So you could have mostly femoral, you could have sciatic. In my experience, and I don't know the data completely, that to have a fibular or a tibial neuropathy that's kind of Parsonage Turner-ish would be less common than more plexus and sciatic and femoral.
Gotcha. Thank you.
You're welcome. All right. These are great questions. I think we could go on all night, but I appreciate everyone tuning in. I hope this was valuable. I hope you all learned. This was a nice way of doing one of these lessons from the lab to get input from everyone, and I'm sure we'll be doing a similar one to this in the future. So have a great evening, and we'll see you all again soon. These are the outtakes.
Oh, that's
They'll be
funny.
at the
I know they're
end.
going to be posted,
Are they?
blasted at the annual meeting.